Good evening, everyone. Welcome to UNC MD PhD Program's 2021 Virtual Mini Med School. If you missed last week's session on cervical cancer, the presentation and recording are up on our website, med.unc.edu/mini-med-school under the presentation tab, past presentations. Tonight is our fourth session for this year's program, and the topic is the thyroid and thyroid disease. This session is also being recorded and will be uploaded to our website within the next few days, so stay tuned for that. Quick introductions of our student panelists. So my name is Miriam. I'm a fifth year in the MD PhD program in the Biomedical Engineering Department, and I will be co-hosting along with Kevin, who is a third year in the program. We also have Nate, a third year, who will provide Q&A and technical support, and I'll be giving more comprehensive intros for our speakers prior to their presentations. We'll have our student speaker present first, followed by Q&A, about a 5-minute break, and then our faculty speaker followed by Q&A, aiming to wrap up around 8 p.m. Eastern Standard Time. If you have any questions about the presentations at any time, please post them in the Q&A box, which you can access at the bottom of your screen. And we'll give you a chance after each speaker finishes presenting to unmute yourself and ask your question. You can also upvote and comment on other people's questions if you like. For any technical issues, please email us at uncminimedschool@gmail.com. All right, let us get started. Loren Oh is our student speaker. She is currently in her 5th year of the MD PhD program and is currently pursuing her PhD in health policy and management, with a minor in quality and access at the UNC Gillings School of Public Health. Her research interests include healthcare delivery reform, access and quality of care for underserved and vulnerable populations, and health disparities. She is active in volunteering at free student-run clinics, including Student Health Action Coalition and Open Door Clinic in Alamance County. Outside of school, Loren can be seen normally brunching with friends on Sunday, playing volleyball, laughing aloud to everything, and snuggling with her cat, Max. Loren, please take it away.
Thanks, Miriam, for that introduction. I like the normally, or perhaps we should say the pre-pandemic era. And before I start my talk, I do want to kind of maybe apologize in advance for any inconvenience caused by my aforementioned cat, Max. She's actually snuggling here right now and might pop into view occasionally just because she likes to be part of the group in action. But with that, I'm going to be talking today about the thyroid and the thyroid disease here. And so the objectives of this session first is really to be familiar with what the function of this thyroid organ is, as well as the hormones that it secretes. We're also going to learn or understand what occurs in thyroid disease, specifically in terms of hypothyroidism and hyperthyroidism. And if these two terms aren't familiar with you today, that is perfectly fine. We're going to be going into a little bit more depth about it later in the presentation. We're also going to try to recognize the signs and symptoms of thyroid disease. And I think this is particularly important as patients, as yourself, or for your loved ones to be able to recognize these symptoms. And if you ever were to experience thyroid disease there. And finally, we're going to be familiar with the doctor's toolkit to assess thyroid disease. And I think this is also, again, important, especially from a patient perspective, to understand what tools the doctor kind of has to approach and to assess and determine a diagnosis of thyroid disease, but also to monitor your condition as it is being treated. So let's start first off with what is the thyroid? And I think this organ itself is one that's less familiar to the general population and compared to the heart and the lungs and the brain. Most people tend to know what these organs do, but I think the thyroid is one that people might be less familiar with. And so the thyroid is what's known as an endocrine gland. And what that means is it's an organ that secretes or releases hormones into the bloodstream that then will act upon other parts of the bodies and affect their function. And so the thyroid is a gland that's actually located in your throat. It's what anterior or located kind of above the trachea or your windpipe. And if you actually want to take the time now, you can actually palpate your thyroid yourself. And so you can kind of place your fingers here on your neck, kind of feel around. You can feel the ribbings of your trachea or your windpipe, but you also might come across a change where there is a little bit of a mass that comes off of that. And that probably is most likely going to be your thyroid. And to kind of confirm that, what you can actually do is you can swallow. And if you feel that mass kind of move up and down, you most likely are palpating or feeling your thyroid there. Now, the thyroid is part of a larger system in the endocrine system of the body. It's part of the machinery that is really driven by the brain and the pituitary gland. And so the hypothalamus, which is a part of your brain, is responsible to secrete out what's known as a thyrotropin releasing hormone, or TRH. And that hormone will eventually make its way over to the pituitary gland, specifically the anterior pituitary, to activate it to release what's known as thyroid stimulating hormone, or TSH. And that TSH will be released into the blood, eventually make its way to the thyroid, and activates the thyroid to release its hormones, which is T3 and T4. And again, this is a well-oiled machine. Secretion or release of T3 and T4 eventually will make its way into the bloodstream to act on the organs themselves, but also goes back to the hypothalamus as well as the pituitary gland and tell them, hey, I've been activated, the thyroid's doing its job, we don't need signals to activate anymore, and kind of decrease, or not shut down necessarily, but decrease that the TRH and the TSH release so that the thyroid isn't being overstimulated. Now, you might have a question, okay, then what are the thyroid hormones? And so the thyroid hormones that we're really talking about in their active forms are known as T3 and T4. And these, once they're released into the bloodstream, can actually have an effect on a lot of different parts of the bodies. It can affect the heart and its function, also have an effect on digestion, brain development, as well as the development of the nervous system. And it also has implications for bone health as well as muscle contractions. Now, if you're a medical student and you're trying to learn all the nitty gritty about the thyroid and its hormones, you can actually use what's known as a mnemonic or a memory device. It really comes in handy when you have a lot of things to memorize. And one of the mnemonics that we tend to use as medical students is the 7 B's of the thyroid hormones. And what that is getting really at each of the thyroid hormones functions, like we said, brain maturation, bone growth, and it can also have beta adrenergic effects. And that's really just a fancy term of saying that there are things in the hearts that get activated so that the heart can contract with more force, pump out a lot more blood, and increase its heart rate. Thyroid hormones can also increase your basal metabolic rate, meaning your metabolism overall is kind of increased, using more oxygen, increasing your body temperature there. And because you're increasing your metabolism overall, you need to make sure that all of your organ systems have energy as well as the source for energy. And so what thyroid hormones also will do is increase your blood sugar by releasing glucose from its storage in muscle as well as liver, and also telling the liver to make more glucose or sugar so that these organs can have the energy that they need. And another way that we get energy is also by breaking down fat. And so thyroid hormones can break down lipids in a process called lipolysis. Now, the final B stands for babies. I think this is important to note because, again, it's really important for development, both of the brain and other parts of the organ systems, but it also can stimulate surfactant synthesis. And surfactant is really just a fluid or a chemical that's created within the lungs to make them nice and pliable or compliant so that it's easy for your lungs to breathe. And so for babies, it's important to have good levels of thyroid hormones because it helps for those lungs to develop and function properly. Now, one thing that's important to note about thyroid hormones is that they need iodine as a nutrient to be created in the first place. And so a lot of you might be familiar with the image on the left, Morton iodine salt, which means that they've really fortified or added iodine to the salt. And so that's a way that you can get enough iodine for your body to use for thyroid hormone synthesis or production. But you can also get iodine in a lot of other foods such as spinach, strawberry, cranberries, watercress, coconut oil. And so ultimately, one thing to note is that iodine is important for thyroid function so that those hormones can be created and sent out to the rest of the body. Now, thyroid disease really happens when there is some sort of disruption, either of the axis that we talked about, where the brain sends the signal to the thyroid, or there's something wrong with the thyroid itself. And so there are various different reasons out there for thyroid disease. It could be that you have a brain disease that affects that hypothalamus. The pituitary gland can also be dysfunctional and not function as well as it should be. And finally, the thyroid itself can have an issue where it either secretes too little hormone, which is known as hypothyroidism, where hypo stands for too little, or it's overstimulated and overactivated and it creates too much thyroid hormones, known in hyperthyroidism. And so that has a lot of implications, like we said, because we know these hormones do a lot for the body in terms of the heart, digestion, brain, bone, muscle, etc. And so when this thyroid production and the balance is disrupted, you can have a lot of symptoms that present in various aspects of the body. And so one of them is a form of hypothyroidism to kind of start off. And I apologize because my cat is now clicking on the mouse. But congenital hypothyroidism can occur for a lot of different reasons, similar to what we said before. Either that axis is really messed up with the brain, or infants might not have a thyroid gland that's properly developed, and so it's not functional. Or infants might actually not be getting enough iodine in their diet or receiving that from their mom when they're in utero or when they're in the wound. And that can lead to a form of congenital hypothyroidism. And that presents in various ways, but some of the presentations, as you can see in these individuals, is presence of a goiter, which is an enlargement of that thyroid gland. Because thyroid hormones are important for brain development, you can actually have mental or intellectual disabilities. And because thyroid hormones are important for bone development, you can result in short stature. Other symptoms that patients with congenital hypothyroidism might have is just an overall general puffy appearance, puffy faces, as these individual has. You can have what's known as a protruding tongue, where the tongue is kind of sticking out of the mouth because it's too big, or a protruding umbilical hernia, where there's a hernia that's really coming out of the belly button. Now, one thing to note about this picture in terms of congenital hypothyroidism, you can see that this is a drawing and not an actual picture of a patient. And one thing to note about that is congenital hypothyroidism, though present in the world, is definitely a more rare case. And the reason for that is developed countries, particularly in the United States, has learned to start screening newborns for thyroid, either a hormone deficiency or an inability to create that themselves. And so newborns that are born, 2 or 3 days after will receive a screening where they take a blood pinprick off of the foot of the infant and use it to kind of run a whole bunch of tests and find out if there's any diseases present. And one of that is if there is hypothyroidism. And so doctors can use medications available and thyroid hormones that we have so that we can replace any hormones that aren't present for this child so that they are able to develop properly. Now, hypothyroidism can also be acquired at a later point in life if you're not born with it. Again, either because of some sort of dysregulation in the axis that we talked immune disorder, and where the cells of the body are recognizing, specifically the immune cells of the body are recognizing the thyroid as foreign or not part of it, and will attack it and start kind of destroying that tissue. And so as a result, the thyroid is not releasing as much hormone as it needs to be or is as functional. And individuals who have hypothyroidism can have an assortment of symptoms, but typically what patients will report is hair loss, cold intolerance, meaning they feel cold all the time, that goiter, that the enlargement of the throat. Also can have fatigue and mood, or general tiredness, mood and memory changes, high cholesterol and lab work, a slow heart rate. You can also gain weight, have constipation, skin and nail changes, so that's drier, more brittle. You can also have menstrual cycle changes there, as well as muscles and general soreness. Now, transitioning over to hyperthyroidism in terms of too much hormone present, you can imagine that it's almost the opposite of hypothyroidism discussed today. And I think that's one memory trick that medical students tend to use. We memorize one aspect, and if we can see the opposite for the other, then it makes a lot more easier to memorize that way. And so hypothyroidism is kind of what we discussed. The signs and symptoms are almost the opposite of hypothyroidism. So whereas hypothyroidism led to kind of cold intolerance or feeling cold all the time, hyperthyroidism, you're much more active, your basal metabolic rate is increased, so you're going to have an increased insensitivity to heat or heat intolerance. You can also have sudden weight loss, frequent bowel movements, such as in the form of diarrhea. You can also sweat more, still have the hair and skin changes there. In terms of heartbeat, rather than a slow heartbeat as seen in hypothyroidism, you can have a rapid pounding heartbeat. You can also have nervousness, irritability, tremors, difficulty sleeping, and similar to hypothyroidism, also changes in terms of menstrual patterns there. Now, one thing to note about hyperthyroidism is that there's a severe complication that's known as a thyroid storm or thyroid toxicosis. It's relatively rare, but it is when hypothyroidism kind of gets augmented or kind of is what you can consider hypothyroidism on steroids. And so this is worsened, especially in the setting of any sort of stress, such as infection and surgery. And whereas previously you're dealing with rapid heart rate or stress or tremors, those get way augmented. And so you can have delirium, as well as increased agitation. Your body temperature can increase to the point where now you have a fever. And you can also get what's known as tachyarrhythmias, which is a special medical term really stating that the heart rate has increased to a point where it's so rapid that the heart is now kind of losing its rhythm and its rate. So to wrap up this session, I'm going to talk really quickly about the doctor's toolkit for thyroid disease in general. And so you can have blood work done, or the doctor can order blood work, and what they can do is they can draw blood to see the levels of your thyroid hormones, specifically T3 and T4. And there are various forms of those thyroids, and they're active or binding, but ultimately the doctor can kind of take a look at those and figure out if you have too much or too little. You can also take a look at the thyroid stimulating hormone, or TSH, and that also kind of gives an indication about how that axis is really functioning. If you have too much thyroid hormones, you would expect that TSH to kind of be low, because the feedback inhibition is telling it, hey, we have enough present. But ultimately, it's a great tool to figure out where in the axis the doctor is really trying to figure out where the problem is. Another test that you can have is something called a radioactive iodine uptake test, or an RAIU. And ultimately what they do is they tag a radio tracer or radioactive iodine and introduce it into your bloodstream. And like we said before, iodine is especially important for the production of thyroid hormones. And so you can imagine that radioactive iodine is going to be taken up by the thyroid gland to create thyroid hormones here. And you can see what they'll do is then they'll conduct a scan to see where exactly that radioactive iodine is located. And so if you look at this picture here, we have a normal thyroid gland, and you can see that the dark dots here is actually that radioactive iodine. And this density is kind of showing that this thyroid gland is functioning normally. You can have, though, in the case of hypothyroidism or Graves' disease here, is there's a lot of uptake and a lot of activity being done because the thyroid is hyperactive and pumping out a whole bunch of thyroid hormone. And so you can see the density of that radioactive iodine increase as we're creating a lot more hormone. On the flip side, you can see in the case of hypothyroidism here in the thyroiditis section is that there's not that much iodine taken up from the bloodstream at all by this thyroid. And so that density of radioactive iodine is much less than what we'd see in the normal thyroid gland. Now, another reason why this scan is particularly helpful is if the doctor assesses any sort of masses located on your thyroid. You can also take a look at the activity level of that mass, or nodule is another way that we say it. And so you can have a cold nodule. As you can see here, there's this density of radioactive iodine located around in the normal thyroid tissue, but this is probably the nodule or mass that the doctor has felt on exam. And looking at this activity, we can say it's a cold nodule, it's a hypoactive area of the thyroid there. On the flip side, we can say that it's a hot nodule. Again, looking at the density of iodine here, we see that this is probably the mass that the doctor felt on exam, but in this case, it's taking a whole bunch of iodine up from the bloodstream, much more so than other parts of the thyroid, and therefore it's hyperactive. And then finally, just to make sure that we're covering all the images located here, you can have also what's known as a toxic multi-nodular goiter. Toxic just meaning hyperactive, multi-nodule meaning that there's multiple masses. Goiter, again, is just an enlargement. And you can see that there are multiple areas here where there's a lot of iodine uptake. And that is just presenting that there is a hyperactive, or there are multiple hyperactive spots in the thyroid. And finally, one thing that the doctor can also do is a thyroid scan. It's very similar to the radioactive iodine uptake test, but it's an imaging test in which they don't introduce kind of another tracer, this time not attached to iodine, into your bloodstream that they can then use to kind of take images of your thyroid, looking both at the size as well as the overall function level of it. And often what you might see is that doctors perform these tests concurrently or at the same time, meaning that they'll do a thyroid scan in terms of the imaging of the overall structure, as well as the radioactive iodine uptake test at the same time to kind of get both pictures there. So with that, I'm going to conclude my part of the session and open it up for any questions that people may have.
Thank you so much, Lauren, for that wonderful overview. We do have a few questions in the Q&A box. Our first question or second question comes from Farazan Akinji-Cole. Kevin, are you able to unmute our guest? All right.
Well, can you read it? Because I don't see my question here. Okay, I see it now. I was wondering if the leaky gut, I wrote it wrong. Leaky gut is related with thyroid issues?
I'm going to actually ask you a question to your question. What do you necessarily mean by leaky gut?
Like where the intestine is kind of like permeable, so lots of things pass through the bloodstream. That's what I mean by leaky gut. I wrote it wrong. I should have put gut there instead of heart. Leaky gut.
Okay.
Because then like, I mean, I'm talking about like gluten and stuff kind of passes through your bloodstream. And I read somewhere, I don't think that's true, that it has same structure as what thyroid is made of. So your body thinks it's kind of like that stuff, your thyroid is, and starts attacking your thyroid. Is that possible?
Yeah, I'm actually might tag you in, Paul, on this question, but so the way that you're describing kind of leaky gut, and I will say I'm not really familiar with that disorder in general. It seems it's more so in terms of like reabsorption or taking up nutrients from the intestine.
And then microbes pass to the bloodstream, and then gluten passes, and gluten has the same structure as how your thyroid is made out of chemically. So since body attacks that stuff inside your bloodstream, it thinks that thyroid is part of it and it starts attacking thyroid. That's what I heard. I don't know how true it is. Maybe I'm talking at a very simple, level, not at the medicine level.
Yeah, I think I have an idea sort of what you're alluding to. So there are lots of autoimmune conditions that run together. And the thyroid, one of the autoimmune conditions for the thyroid is called Hashimoto's disease. And so that one is on part of the genome in our body. The susceptibility for that is very close to one for people that have gluten intolerance, or otherwise known as celiac disease. So people that have Hashimoto's hypothyroidism often have gluten intolerance together. Now, I'm not sure if that causes changes in the gut because of the thyroid, but people that have celiac disease will often have diarrhea, and they'll often have thinner linings of the intestine because of the inflammation there. So I think that probably what you're saying is true, and it's just in a roundabout fashion that's a little bit different in the way that the doctors think about it. Do you have any questions on that?
Yeah, no.
Okay, I'll mute myself again.
And then there was also a mention of the pituitary gland. Sometimes it may be related with pituitary gland, thyroid problem. How do you get tested for that? Is that some kind of a like blood test or something of that nature?
Yeah, so pituitary gland. So there are a lot of different hormones that the pituitary gland secretes or releases into the bloodstream. And in order to kind of test for whether or not that function is present, one, we can get that TSH test that we were talking about earlier that stimulates the thyroid, but the pituitary gland also secretes a whole bunch of other hormones. And so if you can imagine that the pituitary gland isn't working, or you suspect that, you can get blood work to see those hormone levels as well and see if they're lower than normal than what you would expect.
So there are other things besides T3, T4. That's what you're saying, or TSH?
Yeah, so T3, T4 are specifically secreted by the thyroid. TSH is secreted by the pituitary gland. And then there are other hormones that the pituitary gland secretes, just not to get too much into detail, but like follicle stimulating hormone, as well as luteinizing hormone, which is important for like menstrual cycle regulation. It also secretes adrenocorticotropin hormone, or ACTH, which stimulates the adrenal glands. And so there are other hormones besides the TSH test that you can get to see if the pituitary gland isn't working.
I see. And that may be the cause of thyroid. Is that the cause of a hypothyroidism or hyperthyroidism, or both?
So if you have anything where you're secreting too much TSH, you can lead eventually to hyperthyroidism.
Okay.
If you have too little TSH, you can lead to,
Both.
if that's where the problem is, most commonly the problem with hypo and hyperthyroidism is really the thyroid gland itself that's not secreting enough for different reasons. But, pituitary gland dysfunction could technically be disrupted so that, the thyroid is secreting too much or too little in response to the signals it's sending.
Okay, thank you.
Next question is from Daria.
Okay, thank you. So my question is about the regulation of the thyroid on level of the hypothalamus, and obviously the biopathways of hormone regulation, especially on the tropic level, are still being studied. But do you have any insights as to how the nuclear receptors of hypothalamus neurons can detect the levels of thyroid hormones in order to know how much TRH to release?
Yeah, so I'm going to have to tag team Paul on this as well. I think it's a great question, and probably if you're getting more into, I guess, the general mechanisms of that signaling pathway in the cell, I don't have a good answer for you. But you're absolutely correct in that the hypothalamus will have receptors that will sense how much T3 or T4 hormones are in the bloodstreams to shut off that TRH hormone production, but I can't tell you about specifically within the cell mechanisms, if that's what you're looking for, Daria.
It's a great question. My level of understanding kind of taps out exactly where you're at, I think. So I'm not going to be too much help, but you're right. They are nuclear receptors. And, there's differential expression of different proteins in a whole more complicated way that I don't understand as a clinical doctor, where the levels of TRH are related to T3, T4, and probably a lot of other things we don't understand as well too. So it sounds like you're probably interested in that field, and it's great that we have people, especially these MD PhDs, that are kind of digging to that next level.
Thank you.
Thank you. Our next question is from Shreya, and they have asked for us to go ahead and read the question. So, is there enlargement like a goiter in both the cold and hot nodule, even though cold is less active uptake?
Yeah. And so I think that's a great question. So goiter, or the enlargement of the thyroid gland in general, can be present in both hyper and hypoactive of thyroids there. In terms of the specific nodules themselves, I think a nodule is a little bit different from a goiter. So goiter, I feel like, is a general overall kind of enlargement that you see with a bulging neck that is typically present, whereas a nodule is one that you can have a normal sized thyroid, but a doctor kind of feels some sort of bump or mass that's present on there. And that bump or mass or that nodule can be present even if it is cold or a hot nodule, if that answers your question.
All right, and then we have Barbara with a couple of questions as well.
I wondered if the parathyroid glands are related to the thyroid. They sound like they control something completely different. And then a second one, if you're monitoring the thyroid because of past problems, is it sufficient to do just TSH? It doesn't seem so from what you said. Do you need to do T3 and T4?
Yeah, so I'll answer your first question and then I'll pass the second question over to Paul, because I think he can do a little bit more in terms of the clinical reasoning than I can do it justice. But you're absolutely right to think that the parathyroid glands are different in their function. They actually are responsible for helping regulate the levels of calcium within the blood. And they themselves are also an endocrine gland, meaning that they secrete hormones into the bloodstream as well. They're called parathyroid because anatomically what they're located is really close to the thyroid. If I were to draw a picture of the thyroid here, and I'll do so, but please do not judge me for my artistic abilities. But if we can imagine that this is like kind of a thyroid here, I showed you a picture of a thyroid kind of with the wind pipe there. If we were to take the look at the backside of that thyroid, what you can actually see are masses or tissues that are located pretty close or right on, like where with the thyroid gland there, and there are 4 located anatomically, 2 on either side of kind of the wings of the thyroid, again on the backside, and those are the parathyroid glands. But they are very, very close to the thyroid, and if you were ever to receive, thyroid surgery, you can actually lose those parathyroids with that, or nick or mess up their function. But in terms of what parathyroid glands do, they themselves regulate calcium levels in the blood and are completely different from the thyroid. And in terms of your second question, Paul, would you like to talk about monitoring thyroid in terms of TSH and T3, T4?
Yeah, sure. Yeah, so great explanation on the parathyroids. Another interesting point about them is they come from an entirely different part of how the body is forming, and sometimes they'll be in different spots. So sometimes they're up higher in the neck, sometimes they can be down in the chest when the surgeons are removing them for different reasons. But for most people, they end up right next to the thyroid. In terms of the levels, it really depends on what clinical condition we're treating. Loren referenced like Graves' disease, and then there are some pituitary problems. So, for some more complicated issues like newer diagnosis of hyperthyroidism, we'll be checking all of the different hormones. But for someone that has, long-standing low thyroid or hypothyroidism, a TSH is totally sufficient because we understand what's going on. We don't need all the different levels, and our TSH is actually the most sensitive way to detect problems in that whole system. It kind of has a little bit more leverage for smaller changes, so you can see things that are in disarray much easier with a TSH than you might with a T3 or a T4 level. But they're all useful in their own context. I hope that answers your question.
All right, thank you so much for all the excellent questions. We still have a couple, but I'm going to go ahead and call a 5-minute break. So we'll regroup at 7:10 p.m. Eastern Standard Time and make sure that we can get to Dr. Guido's presentation and answer all the questions that we can with the time we have at the end. All right, thank you, everybody. We're going to go ahead and take a break now until 7:10. All right, everyone. Welcome back from your breaks. We are going to go ahead and get started with our second half of the evening. And it's my pleasure to introduce Dr. Paul Guido, who completed his medical school training at Sidney Kimmel Medical College of Thomas Jefferson University and his residency in internal medicine at the University of North Carolina. And he's currently a clinical endocrinology fellow who's completing his training also at UNC with fellowship in the Department of Endocrinology, Diabetes, and Metabolism. He treats adults with a wide variety of endocrine conditions and diabetes in the clinic and in the hospital. He has clinical interests in thyroid disease, tumors of the endocrine system, and the impact of cancer immunotherapy on endocrine function. He also enjoys teaching internal medicine residents and medical students in the clinic and the hospital, and demonstrating thyroid ultrasound and biopsy techniques. Thank you, Dr. Guido, for joining us today.
Thank you for having me. It's really been great to see everything so far. Can you all hear me and see me? Okay, great. So I'll get started. Let's see here. Oh, there we go. Okay. So I have a couple of goals today. And let's see, where's my thumbnail? There we go. Okay. So the first would be to understand how our thyroid hormones are replaced, because there are a lot of people maybe in this audience or conditions that family members have that are being treated with thyroid hormones. It's important to understand kind of how that helps treat these conditions. I'm going to talk about Hashimoto's disease and what it is, and then I'm going to talk about thyroid nodules and goiters, which we've touched a little bit on, and then lastly talk a little bit about thyroid cancer, because it's a complicated topic and can be a little bit scary for patients, but it doesn't have to be. And then we'll have some opportunity at the end to talk about anything thyroid, and hopefully I can answer questions. And then we'll get going from there. So thyroid hormone, so what is it? So we sort of talked about this a little bit already, but essentially you can think of it as the timekeeper of the body. Its job, like Loren Oh said, is to regulate metabolic speed in all the cells of the body. And it's really important to know that the correct levels are vital for survival. So you need this hormone to live. This is what thyroid hormones look like. And I've just highlighted that there's two different versions. And us doctors aren't so smart. There's T4 and T3. And the reason we name them T4 and T3 is because T4 has 4 iodines and T3 has 3. So it's easy to remember what the difference is. And I'll kind of get into detail as to what the difference is, how they function. But they're formed from amino acids, which is all the lines in there, and then iodine, which is an element found in nature, and salt in the United States, or other types of vegetables in other parts of the world. And it's one of the only places that iodine is found in our body. So it's a very specialized use in the thyroid. And it, it's found in iodized salts, like we've seen a picture of earlier. So hypothyroidism, like we talked about, has lots of different causes. So most people are familiar with Hashimoto's disease. There's a good chance that, probably 5 to 10 people in this audience, last time I checked, probably have Hashimoto's. It's about 5 to 15% of people in the country. People that have had their surgery for their thyroid to be removed for various reasons. If you've had radiation for other conditions like head and neck cancer, if you've had a thyroiditis or an inflammation of the thyroid, and this can occur from viruses or autoimmune conditions, or even just because of pregnancy. And then there are lots of medications like lithium or amiodarone or various things that people are treated with for cancer these days that can cause low thyroid. Loren did a great job with symptoms, so I won't hit on them again too much, but you can get, tired and fatigue are people's most common issue. People gain weight, they feel cold, they have changes in their hair and skin complexion. They can get GI issues with constipation, or changes in their periods if you're a woman. But for hypothyroidism, there's one common treatment. It makes it really easy. We use thyroid hormone, made, into this levothyroxine, which is T4, as the one replacement for thyroid in most patients. So I get a lot of questions in the clinic about how, how we replace T4 and not T3. So I wanted to try to clear this up for a lot of people. And I think it's important to understand how T4 turns into T3 and why they're different. So the thyroid hormone here over on the left, and I'm just realizing, is my screen share, can people see that? Is that a problem? Okay. So that should be gone now. Okay.
Oh, sorry, we cannot see your screen share. All looks great.
Okay, so there's nothing blocking it. There was like an active speaker view blocking it earlier. Good. Okay. Awesome. So the thyroid here on the left, is the butterfly-shaped gland, and it produces T4 and T3, but the level of T4 is much, much higher than the T3, and that's just how humans function. Other animals have different ratios, but that's just how we are built. And the T4 and the T3, they make their way through the bloodstream, and the T4 is turned into T3 in the liver and the muscle tissue predominantly, but it kind of is done in all tissues in the body. And it can only be used in the T3 format. So T3 is the hormone that makes its way into the cells, and this finds these nuclear receptors like we were talking about earlier, and they're nuclear because they go into the nucleus, and they cause changes in the DNA there, and this leads to, the effects in each different cell is unique. So it's important to note that T4 is the one that is transporting most of the hormone through the body, but T3 is the one that works inside the cell. So the balance of the hormones is important, and the reason because of that is T4 is our storage form. So you see the picture of the oil depot here. You can think of T4 as our like reserve. You can't use it directly, but we can refine it and we can use it when we need it, but there's a lot more of it and it's a lot easier to store. It's not quite as flammable as gasoline. T3 is our active format. So it's what our cars run on, it's what our cells in our body run on, and you only use what you need. So it's not good to have these big tanks full of gasoline. We keep it as crude oil because it's a lot less dangerous. So the reason for that is because the T3 level fluctuates a lot more. So this chart up here is an example of if the person was given pills of T4 or T3. So T3, I'll go back. T3 you have to dose every day, and the levels go up and down and up and down and up and down. And the patient will notice this, and they'll, experience wide variations in their gasoline level throughout the day. Whereas the T4, when we give this to patients, it builds up a nice depot, and the body, you can't see in this chart, will use and turn it into T3 when it needs to. So it's much more stable for the patient when we give a T4 or levothyroxine replacement and let the body convert it into T3 when it needs it. And that's kind of the rationale as to why we use levothyroxine, or Synthroid is the brand name that people are aware of, to treat people with hypothyroidism and not T3. There are select situations that I'll get to in a little bit. So what are the thyroid levels? I think Loren did a really nice job explaining kind of this whole system that's very finely tuned. It is very easy to interrupt, but you can kind of think of it like the cruise control in your car. And what this will do is kind of regulate things automatically. So if you think about the analogy, so the brain or the pituitary gland and the hypothalamus, can everyone hear me? I'm getting an internet warning. Good.
It was a bit choppy, but I think we heard you in spurts.
Okay, is it better now?
Yes.
Good. Okay, sorry about that. I'm on the whim of Spectrum here. So the brain is sort of like the computer. It kind of tells everything what to do. The TSH is like the gas pedals. It doesn't actually drive the car, but it tells the car how fast to go. The thyroid is your engine, right? It's producing all of the horsepower, the output. And the T4 and the T3 are like the speed. So that's kind of the end result of the whole system is your thyroid hormone levels. So if you're going too slow, you think about it, the cruise control makes a decision with the TSH for the gas pedal to give the engine more gas, and that'll produce more speed. If you're too slow, then the opposite occurs. So the cruise control will let off the gas, and the T3 and T4 levels will go lower, or speed will go down. So the TSH is kind of like the opposite of how fast the system is going, to be that way. So I think we had a question in the chat earlier about why don't patients feel normal when they have normal TSH levels? Well, it's important to remember that the TSH is the most reliable measurement of how the system is working. It's the most sensitive, but it still is within a range. So this bell curve is representative of the entire population of patients. So they took blood from hundreds of patients or thousands of patients, and they averaged the levels, and they said, okay, more people have a TSH around 1 than they do around 4, or then around 0.5. But we'll still call this normal because all these patients did not have hypo or hyperthyroidism. So most people, or most endocrinologists, would consider anywhere between 0.5 and 5.0 a normal thyroid stimulating hormone level. But that's not for this particular patient. That's just where they fall in this bell curve. So it's important for the doctor to understand where they belong in that range to figure out what makes them feel normal. So if you're up here and your TSH is 3 and you're tired, you might not feel normal until you're down around 1.0. That just could be your spot on the curve. But it's important to note that outside of these ranges, when we're talking above these red lines, where things start to get more dangerous. So if something is not working and you're still feeling poorly, but your TSH is floating on down here closer to 0, there might be something else going on. Okay, so biotin, we get this issue a lot. So it's important for patients to understand that biotin is over the counter. It's a supplement that people take to make their hair, skin, and nails look better, which is a common complaint that people with thyroid issues have. They just don't feel good because their nails are brittle, or their hair is falling out. So they take this, but it can actually get in the way of the lab reaction. So this is a very complicated slide here, but I'll try to make it easy. So this is your sample in a patient that doesn't have biotin. The blue stuff is your TSH. And you'll notice that the lab chemical actually has biotin, this green thing on it, and it helps it attach to the chemical that the lab reader uses. So you need the biotin to be at a precise level in order for the lab reaction to work. Now, if someone's taking a bunch of biotin, like in this supplement here, and nothing against Nature's Bounty, that's just the picture I found on Google, the biotin in red here is not the precisely measured green one, and it gets in the way, and it makes your TSH levels look like they're artificially lower than they should be. So people that have thyroid problems probably shouldn't take biotin when they're getting the labs tested. Just something FYI for patients. So what are the complications of too much thyroid hormone? So like Loren was talking about, if you have too much, you're essentially giving yourself hyperthyroidism. So it's fine to treat within that normal bell curve that we talked about. But if you're on the lower side, you remember kind of below that red line, it's like revving the engine in our analogy for too long. So start to break down the parts, and you have issues like atrial fibrillation or heart failure. It also makes the bones metabolize too quickly, and you can get things like osteoporosis or high blood calcium, and it's just not good for the body long time. So that's really why we try to tell patients that you can change things within that certain range, but it's not a good thing to go outside of them for too long. Oh, this slide is totally broken. Let's see if everything comes up. Okay, good. So I'll just go from top to bottom rather than use the animations. So there are a lot of misconceptions out there in like the lay press or just kind of like, on message boards. But here are just a couple common ones I get asked all the time. And number one is that iodine supplements can fix hypothyroidism. In the United States, it's very rare that someone's actually truly iodine deficient. Like we said, every form of salt that's in our fast food chain or packaged supply or in your pantry has iodine in it naturally, because the United States has decided they want to eliminate congenital hypothyroidism. And it actually may make things worse due to a protective mechanism, and that's because the body doesn't want to have too much iodine or thyroid hormone in the body at once. A lot of people are on Armour thyroid out in the public, and some people think that that's more natural and better for the patient. But it's a common misconception. Now, yes, it's true, it will keep you alive and it will keep your thyroid levels normal, but it's the same kind of molecule in Synthroid or levothyroxine that your thyroid makes. There's no difference. The Armour thyroid is actually a dried, ground up animal thyroid. And because of that, they can't actually get the dose exactly right. So the levels are fluctuating, even from pill to pill. So it can be a little challenging for us to dose it. And then that T3 hormone level is less stable because in the animals they get it from, the ratios are different just based on that animal's makeup. And then some people will say that they need a mix of T3 and T4. Now, this can be true for some patients, but most patients get by just fine with levothyroxine. And the American Thyroid Association is our main kind of go-to for guidelines, and they have not found enough evidence at this time, based on research, that all patients should be treated with T4 and T3. So we'll trial it for some patients, but it should be kind of a last resort thing and not a first line treatment. Okay. So I'm going to skip my question slides and just wait till the end if that's okay. And we'll just save, because I know we're kind of running tight on time. So what is Hashimoto's disease? Who gets it? And what else is associated with it? So I like this cartoon. I also found this on Google. I don't have any particular kind of relationship with this cartoonist, but the thyroid is sort of where the body rises up and has a reaction against the Hashimoto's. It rises up and attacks the thyroid, essentially. So like a mutiny or like overthrowing kind of the king. So it's autoimmune, and it's these antibodies, TPO. It's thyroid peroxidase is the antibody, the fancy name, and is often painless. People don't know it's happening, so it just happens, and then they get hypothyroid, and they don't know until they're feeling tired and they've gained some weight. A small minority of people will have tenderness in their neck, or they might get a goiter if there's some inflammation to cause swelling. There's no known treatment at this time. We don't know how to stop this in its tracks, but we do know that once you do have hypothyroidism, that you can replace the hormone and therefore, keep people feeling good and healthy. So here's a microscope picture of the thyroid normally on the left here. And you can see the nice healthy kind of lakes or follicles of thyroid hormone, that purple surrounded by the cells that make it. And then on the right, you can see it's kind of just all out of whack. The immune system, all these purple dots have come in, and there's barely any purple lakes left. So this is kind of late Hashimoto's disease there when the pathologist will look at a biopsy. So who gets Hashimoto's? Like I said earlier, these antibodies are very common, like 10 to 20% of people will have them, but only 5% of people will develop full-blown hypothyroidism that need replacement with hormone levels. Having the antibodies does give you a little bit risk per year, 5% per year, but it doesn't necessarily mean that you will develop hypothyroidism. So your doctor just needs to keep an eye on TSH levels, or if you have symptoms, consider testing for them. Hashimoto's is a lot more common in women. We don't fully understand that yet, but we do understand that risk increases with age, more common in kind of middle-aged or normal-aged people. It's genetically linked, like I was talking about earlier. It's on these HLA alleles that are inheritable through your family. It can be brought on, this autoimmune disease. We think all of them need a bit of a trigger, and that can be just stress in life or a pregnancy that changes your immune tolerance. If you have too much iodine, if you have a viral infection, that can trigger it. And there are lots of other autoimmune conditions that are associated with it. So celiac disease, like we talked about earlier, where you have gluten intolerance, type 1 diabetes can be associated with Hashimoto's. vitiligo, which is a skin condition where your body will attack the color-producing cells. And then Addison's disease is an adrenal condition where you don't make enough cortisol. These are all related sometimes on this these alleles that patients have. Again, I'll keep moving on forward. So subclinical hypothyroidism is the last topic I'll talk about for low thyroid. This condition is very common. It's when the TSH levels, if you're checked on blood work, are out of range. So somewhere between 5 and 10 usually. So remember, the higher the TSH is, that's hypothyroidism. But the normal, the T4 level, so like we're talking about the end hormone level, is normal. And these patients most often will not have symptoms. So it's subclinical, or you would not recognize it clinically until you got blood work done. But we think that because the thyroid hormone is so important for our metabolism, especially the heart, that it increases the risk of heart disease, high cholesterol, especially in people as they get older. So it is a serious thing to think about treating for some people. There's also a risk for pregnancy. Like Loren was talking about, the babies really need thyroid hormone to develop appropriately. So we think that subclinical hypothyroidism is important when you're pregnant too. So it's a balance. We don't want to have to treat everyone that has just a slightly abnormal lab number, but we do want to make sure people don't have heart attacks or have birth defects when they're pregnant. So if your TSH is above 10, despite your age, you know, it doesn't matter what age you are, we'll treat you. If you have low thyroid TSH, TSH between 7 and 10, we'll treat patients above 65. And then if it's above normal, so that depends on your lab, but most are around 2 to 3. We'll treat women who are planning a pregnancy just to make sure the baby has their best chance to develop normally. So it is a balance. So we'll switch gears now to thyroid nodules and goiters. We had a lot of questions about that earlier, and we can kind of clarify things, but really we're just going to talk about what are thyroid nodules, what are goiters, what are some symptoms of that, and how do we diagnose them. So a thyroid nodule is a benign or a cancerous growth. So you can't tell just based on feeling it, which type it is, but they're very common. So we know most likely it's not going to be a cancer. It's increasing in frequency as we age. So, you know, it goes from 3% when you're, you know, in your 20s, all the way up to 20% when you're over 50. So, you know, by the time you're an old man or an old woman, you probably will have some kind of nodule in your thyroid if you go looking for it. And what causes these? There's a lot of different what's called etiologies or reasons for these nodules to form. Now you can have a cyst, like anywhere on your body. You can have a fluid collection in the thyroid, and that can form a bump. You can have functioning nodules, which Loren showed a great picture of, the hot nodules or the multi-nodular goiter that makes extra hormone. And these can cause hyperthyroidism. You can have solid nodules that are just mass of different tissues. And these can either be benign or malignant. And malignant just means that the cells are growing in a way that is not normal. They're growing too quickly, and they're growing outside of the normal boundaries of the tissue that they come from. So they can sometimes even leave the thyroid. And a good analogy for people that have never heard of thyroid before is sort of like a mole versus a skin cancer. So lots of people have moles, and they're, you know, benign tumors, right? So a mole is just a growth on the body, but it's not a cancer. And it's totally different than something that is a cancer, like a melanoma or a basal cell. But they can look very similar, and it's important that they get checked out and made sure that they look normal under the microscope or under an image or clinically. So a goiter is simply just a term for an enlarged thyroid. And classically, you know, before iodine deficiency was kind of eradicated in developed countries, the most common cause was because of an iodine deficiency. But that's not really a thing in the United States because of our food supply chain. It's common to have a multi-nodular goiter. We saw that picture earlier where you have lots of bumps, and that can cause the growth in the thyroid gland. Something like Graves' disease, which we don't really talk about too much in this topic, but is a cause of goiter and thyroid growth. Different types of thyroiditis can cause goiter, and then thyroid cancer can also be a cause of goiter. So again, it's important to investigate why someone has a goiter rather than just saying, oh, it's a goiter. We have to figure out the underlying cause. So what are the symptoms of a thyroid nodule or goiter? So as you can imagine, having a bump in the neck can be something that's really hard to feel, or it can be really obvious. So you could even see it in like a family picture and someone may pick it up, or you could be a TV anchor and some of your constituents will call in and say, hey, it looks like you have a goiter. But other than just the appearance, people can have trouble swallowing. They can get kind of a raspy voice. They can have hyper or hypothyroidism that we talked about earlier, or they can have no symptoms at all. So how do we diagnose thyroid nodules and goiter? So typically, once you feel it on exam, or there's a concern for it, we use what's called an ultrasound machine, which most people are familiar about from looking at babies when people are pregnant. But it's the same technology. It's harmless. It just uses sound waves. And it can produce a nice crisp image of what's inside the neck. So here you can see the thyroid ultrasound technician or the doctor using the probe, and then you can see kind of where the thyroid is getting hit by the sound waves. And here's a nice cross section, so sort of looking through the neck. In this gray area, the nice kind of smooth gray area is the thyroid. These tissues above it are the neck muscles and the skin. And then right in the middle here is the windpipe. And these two are your carotid arteries, or the pulse points on your neck. So on the ultrasound, we can see lots of different types of thyroid lumps and bumps. So here up top on the left is a thyroid cyst. So this is a fluid collection. You can tell it's fluid because it's nice and dark. On ultrasound, the darker it is, the more likely it is it's fluid. And we always compare it to the artery, which contains blood, which is a fluid. So that's a nice benign looking cyst. Here in the middle, we have a multinodular goiter. And this is a pretty common appearance where they look different. There's lots of different appearances to different nodules. So this one's more solid, that one's got more fluid in it, and this one's kind of both. It's called solid and cystic. And then we have one up here, which is a thyroid cancer. And this one kind of looks a little bit darker, but it's not so dark as fluid, and it's got these little bright spots in it that might be calcium. And those are some signs that we might consider a biopsy. So how do we look at thyroid nodules over time, and how do we grade them if we're not going to biopsy them? So your endocrinologist or your radiologist might use something called a Tyrad score. So this is our agreed upon way of ranking different nodules to try to figure out, does the ultrasound convey any different risk based on how they looked? And based on the score, you might just say, oh, we can stop following this entirely, or you might need a biopsy. Or some doctors may choose to do a bunch of ultrasounds in a row and then consider a biopsy. Or you might get a bunch of ultrasounds and say, okay, it's not too worrisome, we can stop following it. But the more points you get, the more likely you are to need a biopsy, essentially. So how do we biopsy a thyroid nodule? So we use a technique called a fine needle aspiration. And most doctors will just explain this as a biopsy. But we use a very tiny needle, and it's about the size of an insulin needle. If anyone has diabetes or family with diabetes that use insulin, it's a very, very skinny needle. So we poke this through the skin of the neck under the supervision of an ultrasound machine, so we can see exactly what we're doing when we take the sample. And then we draw back on the syringe a little bit and take a small sample of cells out for the pathologist to take a look at. So here's a picture. You can see the tiny needle, it's long, but it's very narrow, going into this nodule here in this person's thyroid and taking a sample. So the way we do it at UNC is it's an office procedure. We do it in our endocrinology clinic. There's no special preparation needed. It's sort of like, if you're getting a skin biopsy in the dermatology office, or your dentist is getting a filling, it takes a little bit of setup, but it's easily done, and you don't have to get anesthesia or go into the hospital. We clean off the neck with an alcohol swab, and then we only actually have to use numbing spray, so like cool spray that you might get to place an IV or get a blood draw. because the needle is so tiny, we don't need to use lidocaine. And we use a 27 gauge if you're familiar with sizes like an insulin syringe or a flu shot size. And we take the small samples of the cells and we send them to the pathologist, and you can go right home after you get your biopsy done. So no special preparation needed. This is what it looks like when we do the biopsy. So this is a fancy aspiration tool. So it helps you guide it and pull back on the syringe at the same time. There's the thyroid cells. They look a lot like blood, but it's not blood. It's the thyroid hormone. Essentially, it's kind of red in color. And then in it, on the right here, you can see the different cells, and the pathologist can take a look under the microscope and use their skills as specially trained doctors to tell us if these look A-okay or if they look like something that's worrisome for cancer. So we, most of the time, will get a nice, good answer based on a thyroid biopsy. Again, save the questions toward the end. So lastly, I'll talk a little bit about thyroid cancer because it's worrisome to hear about cancer, but thyroid cancer is a little bit different. It's much different than other types of cancer. So we'll go through what causes it, how do we detect it, how do we treat it, and then maybe some advances just to kind of give some exciting new technology for people to be interested in. So it's not a common thing. It's 1.3% of people in their entire life will have thyroid cancer. So less common than lung cancer or colon cancer or breast cancer, but it still affects people in this country. About 15 in every 100,000 people will get thyroid cancer each year. Almost everyone survives though. You can see here on the bottom, this is the rate of thyroid cancer in the light green squares. And that's been going up over time. And we think that's probably because we're just getting better at detecting and finding it in people. But the people who pass away from their cancer has stayed about the same, over the last 30, 40 years. So at 5 years after diagnosis, 98, almost 99% of people will survive their thyroid cancer. So it's a very treatable condition. And we're very fortunate that we have lots of good tools to treat it. So what causes thyroid cancer? So thyroid cancer, like any cancer, is due to mutations in the thyroid cells that cause them to grow out of control and abnormally compared to the normal thyroid gland. And some of these mutations will just happen on their own through just random chance. And you can see a image of a DNA mutation here. Some are inheritable. So patients that you may have heard of things like the BRCA gene for breast cancer. There are some genes that pass a risk of thyroid cancer on from mother or father to child. And then we think that radiation is actually probably our biggest risk factor for thyroid cancer, especially at a younger age. So we're talking about really high doses that might be used for some childhood cancers like lymphoma, or patients that were exposed to nuclear accidents like Chernobyl. But those are risk factors for thyroid cancer. How do we detect it? So people are probably feeling their neck and trying to feel things, and that's okay. Most people, get concerned after this talk, but it's nothing to be worried about. But sometimes people will feel a lump in their neck, and that will lead to a test. But most often, actually, up to 60% of patients will actually find a nodule on other imaging tests. So we'll have people get like a neck X-ray or an MRI. Or an ultrasound of their blood vessels, and they'll come in and tell us, hey, my doctor found a nodule in the thyroid just by accident. And we'll take those very seriously and make sure that they look benign on the imaging and get a biopsy if they need it. Now, there's no standard screening regimen in the United States. It's sort of like how patients get mammograms when they turn 40 or 50 or get a colonoscopy. There's lots of studies done by these governmental agencies called the USPSTF, and they've done an analysis of what would happen if we screened everyone versus what would happen if we only screen people that come to our attention. And they found that there would be too many unnecessary biopsies and surgeries. And we all know that surgery, while it's very safe, does carry risk. So they have found that for thyroid, at least, because it is less common, it's not something that we need to screen every single person for. Now, there are select patients that should get screening for thyroid cancer, and that's for people that have a very strong family history of thyroid cancer or other cancer syndromes that I've listed here in this slide. And then some children that have had cancer at a young age that have had radiation should get screened for thyroid cancer as well. But for the most people, there's no need to get screened for thyroid cancer. So how do we treat thyroid cancer? So in 95% of patients, it's limited only right in the thyroid or sometimes in the lymph nodes around the thyroid. So most people will get what's called a hemithyroidectomy or a total thyroidectomy. And this simply means removing half the thyroid or the whole thyroid. Sometimes the surgeon will choose to do a lymph node removal from the sides of the neck, but most people do not need that done. And you can see in this picture, here's the thyroid with the nodule, and they've removed half of it or the whole one. And this is just your windpipe underneath the thyroid. So what is thyroid surgery? So it's a surgery. It requires a general anesthesia and an anesthesiologist. But it's usually done same day, so in like an outpatient surgery center, or if they think you're a little bit high risk, you might need an overnight hospitalization. And it typically leaves a very small, sometimes even undetectable scar in the neck. They only need a very tiny incision to remove it because it's a very small gland. And you can see the anatomy here. This purple thing is the thyroid. Your windpipe is underneath that. And then you have some important arteries here, like your carotid and your jugular vein. And then there's some important nerves underneath there, like the laryngeal nerve that controls your voice box. And then, like we talked about earlier, the parathyroid glands are right underneath there. So you can see it's a very delicate space, and the surgeon has to be pretty good. So as an endocrinologist, I'll only send people to a thyroid surgeon that I trust that does many thyroid surgeries per year, so I know that they have capabilities. And we know based on studies that you do better if you have a surgeon that does more thyroid surgeries per year. So that's an important thing to note. So how do we monitor people after they've been had their surgery? Because most of the time, this is actually a cure. So surgery for thyroid cancer is unique in that it will cure people, 95% of the time. So we're still cautious. We still like to make sure that people are getting good follow-up. So we'll do an ultrasound of their neck and make sure there's nothing growing back. We're lucky that we have a tumor marker that in the bloodstream can tell us if there's signs of thyroid. So it's called the thyroid globulin. And then we're using our thyroid medication to actually keep people alive by replacing the hormone and also preventing any thyroid from growing back. So if you remember that diagram, this TSH hormone is something called thyroid stimulating hormone, and that actually tells thyroid tissue to grow regardless of where it is in the body. So we can keep that level down with the levothyroxine and actually try to prevent any tiny microscopic parts from growing back. So it's called TSH suppression. For advanced thyroid cancer, which is less common, we will sometimes use radioactive iodine treatment, sort of like those images that Loren showed us, but at a higher dose. So this will be used to kill off any microscopic amounts of thyroid that is spread throughout the body. And it functions sort of like chemo or radiation, but it has no traditional side effects like nausea or hair loss or anything like that because of the unique properties of iodine that only concentrate iodine in the thyroid. So how do we do this treatment? So step one, we will lower the thyroid hormone levels in the body, and this will prime the cells in the thyroid or anything that's left for treatment, and this takes about a month. Then we'll do a low iodine diet, and this will make the cells hungry for the iodine that we're about to give for about 2 weeks. And then we'll administer this special isotope or radioactive format of iodine. Now, this is just kind of like a pill or sometimes a liquid, depending on what hospital you go to, and it gets quickly absorbed through the stomach and it doesn't cause any harm to the rest of the body. And then it works in the thyroid or what's left of the thyroid to kill any microscopic cells. And it has minimal symptoms to the patient. Now, some people get a little bit of dry eyes or dry mouth due to the radiation treatment, but it goes away for almost everyone. And then you only have to stay away from people for like 2 or 3 days from close contacts in your household. All right, so my last 2 slides are sort of recent discoveries for thyroid nodules. So we're very lucky to live in the age we do because we can do personalized genetic testing for individual people. The way we look at genes under technology has become so cheap that we can just test anyone that needs it. So in the past, on the left here, if you had a gray zone on your biopsy, this would often lead to surgery. So 75% of people that had an indeterminate or gray zone biopsy on a nodule would get their thyroid removed, would get it removed unnecessarily. So that would be a benign result when they took it out. Now we use these fancy genetic markers based on the biopsy result alone to tell us whether something is suspicious or benign. And that really reduces our rate of people that get unnecessary surgery. So we'll do this on a daily basis in our office. We have special vials that we send the thyroid cells in, and they can amplify the gene technology to look at the genetic risk of each person. And we are also developing better chemotherapy for the very rare patients that have thyroid cancer that has spread. So we can use our information from genetics to understand exactly what went wrong in those thyroid cells and have a couple of drugs that actually target those gene-specific mutations and kill the cancer without causing the traditional side effects of chemotherapy. So it's a really exciting time for treating thyroid cancer and thyroid nodules and thyroid disease in general because of the advances in technology and medicine that we have. So with that, I think we have about 10 or 15 minutes for questions. I'll leave our summary slide up here and we can go ahead and answer questions at this point.
Thank you so much, Dr. Guido, for that overview. We do have a few questions up on the Q&A board. Let's go ahead and unmute Carolyn or Caroline. All right, go ahead and feel free to unmute yourself, Carolyn.
Okay. My question is, if you've had your thyroid removed and you're on levoxythyrazine, and for some reason you run out of medication, or there are days that can't take it, how life-threatening is that? I've never known what would happen if you.
Yep, that's a great question. So it's very important. So it is a life-sustaining hormone. So it takes a long time to get truly very sick from running out of thyroid hormone, but if you stop taking it or you run out and you can't get it and you truly are dependent on it from having your thyroid removed, you can go into a coma and people can die from it. It's very rare. It's hard to get there because thyroid hormone is a very stable treatment. So it takes several weeks to months to get sick from it. So for people that do take it for, having a thyroid removed, you don't have to worry about missing a dose. You can just take the next day or 2 or 3 days later. Yeah. But if you've missed, 3 or 4 weeks, you should see your doctor and talk about how to restart it safely and give them a call right away.
Okay, thank you.
Yeah, of course.
All right, our next question is from Firuzan.
The first question I have is, if you have hyperthyroidism, does that mean eventually you have to have your thyroid removed? Is that true or not? Or can you live forever, using the medication? That's the first
That's a really good question. So for hyperthyroidism, there's lots of different causes. And the most common one is something called Graves' disease. And it's not grave as in a bad thing. It was just Dr. Graves who discovered it. Now, Graves' disease is an autoimmune condition similar to Hashimoto's, but unlike making for Hashimoto's that makes you hypo, this makes you hyperthyroid. And sometimes it'll go away. In about 50% of patients, it'll actually go away on its own. And we don't fully understand why that is. So for some cases like that, it'll just kind of go away and you just need to take medicine for a while. Now, there are some cases like the other half of people with Graves' disease where they'll need something like surgery. We can also use the iodine treatment like we talked about for thyroid cancer to get rid of the thyroid gland without doing surgery. There are nodular thyroid diseases that sometimes need surgery to treat their hyperthyroidism. So it really depends on what type of thyroid disease they have in order to figure out what type of treatment they need for their hyperthyroidism.
Okay. And then I had a question about this genetic testing to get yourself genetic tested. And I think Nathan said that they have the testing capability, but it has to be clinically indicated, meaning what will justify it to be clinically indicated?
That's a great question. Yeah, so these tests are studied on the thyroid nodular cells themselves. So they're not like a blood test that you can just get done and tell you your risk. I wish we had that kind of technology, but these are studied based on if you have a nodule or something that's suspicious for cancer, and the pathologist can't figure out what it looks like under the microscope. So they just come back to us and say, sorry, we couldn't figure it out. You're going to have to figure out another way to tell whether this person has cancer or not. So
it has to be a cancer risk. Is that the only case?
Yeah, for thyroid nodular testing, the only indication is to try to figure out whether it's a thyroid cancer or not.
No, I'm asking about the genetic testing.
Can you rephrase it in a different way? I'm just having.
You talked about the genetic testing, that you can do genetic testing on the thyroid, and then I think Nathan answered, and he said that you have to have to be clinically it has to be clinically indicated. I was asking what it means clinically indicated.
Right.
What's the justification? Yeah, what's the justification to get genetic testing for it?
Gotcha. Yeah. So the clinical indication just means that the doctor has a concern for something. And the only kind of indications we have right now or concerns are for cancer.
Yeah. Okay. Thank you.
It's a good question, though.
And for now, it looks like our last question is from Daria.
Thank you. So when you were talking about hypo and hyperthyroidism, you showed us like the different levels of these different hormones, and it looked like hyperthyroidism has a wider range of hormone levels that are indicative of it, and then this, thyroid disease in general, for instance, Graves' disease, which is very common, has hyperthyroidism in general, and Hashimoto's is presented as hyperthyroidism in the beginning. So why is it that hypothyroidism is more common in the US? Is it like just a human genome thing?
Yeah, that's a great question. I don't know the exact answer to that question, and you've stumped me twice now, which is really good for you. I think you have some great questions. The autoimmune condition for Hashimoto is like that antibody is very common. Now, why that is, I'm not entirely sure. It may be, just how that allele or that haplotype has been inherited through the human race over time. But we know those specific haplotypes. I don't know them off the top of my head, but there's 3 or 4 that convey risk for like Hashimoto's and type 1 diabetes and celiac and things like that are prevalent and common. And then there's some kind of environmental or stressor or second hit hypothesis that will trigger that autoimmunity. And because it's an autoimmune condition and it's so prevalent that causes hypothyroidism, that's why Hashimoto's hypothyroidism is one of the most common conditions in the country. Sort of like type 2 diabetes, right? Another endocrine condition we treat as endocrinologists. It's very strongly genetically linked and much more prevalent than hypothyroidism even, and people are set up at risk just because of the genes they inherit.
Yeah, thank you. But isn't Hashimoto's disease typically starts out with symptoms of hyperthyroidism, like because of leakage in the thyroid or something like that?
Oh, yeah, I see what you mean. Yes, so Hashimoto's in rarer cases can have a brief period of autoimmune inflammation that will cause will cause destruction of the thyroid. And if that happens quickly, which is uncommon, like enough to cause symptoms and be detected, if that happens quickly, all that thyroid hormone that's stored up in those like beautiful purple lakes will be released into the body at once. And that can cause hyperthyroidism for a transient amount of time, but almost all of those patients will end up low within weeks. And it's hard to catch that because it's not as severe as Graves' disease or a multinodular goiter. People just get missed. So either it's silent or it's missed, or we're lucky and we catch it for, 1 or 2 patients a year. For me, I would say that have Hashimoto's hyperthyroidism in that brief period. But it's important to understand that the long-term consequence of Hashimoto's is a low thyroid.
Okay, thank you.
Looks
I
like
hope
we
that
have,
answered your question.
thank you. Looks like we have one final question before we wrap up for the evening from Firzan.
The question I had was, is it like normal to have a high cortisol level when you have hypothyroidism? And then what's the risk of having high cortisol if that's the case?
Yeah, that's a great question. It's a complicated topic, and there's not one specific answer to the hypothyroidism question. Patients that are under stress can have a high cortisol. So if they're stressed from hypothyroidism, that can lead to a transient elevation in cortisol. But more commonly, because hypothyroidism will slow down your metabolism, it will make you have a lower cortisol. Now, whether these are clinically relevant or not, whether they cause symptoms of low cortisol or high cortisol, is hard to say. But for most patients that have low thyroid levels, they don't have clinically relevant, for most people that have hypothyroidism, they don't have clinically relevant aberrations in their cortisol level. Okay. Now, high cortisol is a totally separate endocrine condition, and it's sometimes called Cushing's disease. And there are a lot of risks, sort of similar to like hyperthyroidism. It can cause heart issues or bone problems. It can cause diabetes. It can cause all sorts of different things. And it's analogous to just taking a bunch of prednisone for a very long time. And if you've ever taken prednisone, it doesn't make you feel great.
Mm-hmm. Thank you.
Of course.
All right. With that, we're going to wrap up for this session. Thank you so much to all of our attendees for joining us tonight and for your engaging questions. Thank you as well to our speakers, Loren and Dr. Guido, for your time preparing your presentations and answering all of our wonderful audience Q&A questions. Shout out as well to the panelists for your technical support, and again, for all of the students who are on the Mini-Med School Committee. With that, I just want to say I'll see you all, hopefully, or many of you all next week for our final session for this year's virtual Mini-Med School. If you can believe it, we have reached our 5th and final week next week, and that will be on health equity on Tuesday, March 2nd. That'll start as usual at 6:30 p.m. Eastern Standard Time. As a heads up, we may have a shorter session for this one as well with just our student speaker, like we did for the cervical cancer session, but it will still be recorded with Q&A as usual. All right, good night, everyone. If you have any questions, please email us at uncminimedschool@gmail.com. And until next week, take care, everybody. Bye-bye.